Hello everyone. I'm Andreea Lacraru. I work as a cardiologist in an emergency hospital in Bucharest, Romania. And I'm happy that I was part of this interesting project. I'm very sorry that I couldn't be there with you. And I will present the results of the pilot phase for patients with heart failure. According to the European Heart Failure Guidelines published in 2021, cardiac rehabilitation is recommended for all patients who are able in order to improve the quality of life, exercise capacity, and reduce heart failure hospitalization. Our aim of this study is to ensure the continuity of medical care and access to personalized cardiac rehabilitation program at home for patients with cardiovascular disease using the vCare system. Next slide. Okay, thank you. The start of the pilot test was initially scheduled for December 2021, but due to the pandemic situation, the rehabilitation activity performed at Baghdasar Arseni Clinical Hospital have been suspended between January and February 2022. This also affected all activities within the hospital regarding examinations and enrollment in the vCare project. But starting mid-February, part of the restriction was suspended and we could recruit the first subjects. Also, we have some delays in receiving the devices needed for the pilot test, and due to this aspect, the enrollment process was delayed, which led to a shorter monitoring period. Screening of patients was done according to the inclusion and exclusion criteria. To the eligible patients, we presented the project protocol, and after signing the informed consent, the clinical evaluation was performed. A total of 30 subjects suffering from heart failure were recruited and divided into three groups, each consisting of 10 patients. The experimental group that performed cardiac rehabilitation at home using the vCare system, the ambulatory group that performed conventional cardiac rehabilitation at Baghdasar Arseni Hospital, and the control group who only received at the church advice for performing physical exercise at home and suggestions regarding the reduction of cardiovascular risk factors. Here are the inclusion and exclusion criteria. The inclusion criteria were represented by patients with heart failure class 2 or 3 NYHA, availability to interact with digital devices, high-speed internet connection, and the presence of TV screen with an HDMI port. Next slide, please. At the beginning and at the end of the rehabilitation program, a battery of evaluation scales and tests were administered by a medical doctor and a physical therapist to evaluate effort capacity and lifestyle changes of the patients. The baseline assessment consists of a quality of life measurement perceived by the subjects and portrayed by Euro Quality of Life 5 dimensions. Secondly, the patients were clinically characterized by performing an ECG stress test used to assess patients' exercise capacity and establish a personalized cardiac rehabilitation program. Performed at the time of inclusion at the end of the rehabilitation program, it serves as a coherent data collection tool for comparing rehabilitation outcomes across the process of continuity of medical care. Also, we perform the patient were characterized using the Fagerstrom test for nicotine dependence, the head scale to assess anxiety and depression symptoms in medical patients, the Minnesota Living with Heart Failure instrument, which assesses the quality of life among patients with heart failure. The primary outcomes of the project was improvement of the quality of life evaluated by Euro Quality of Life 5 dimensions, and the secondary one, the reduction of risk factors. At the end of the cardiac rehabilitation project, the subjects assigned to be in the experimental group were asked to complete 3 evaluation scales and aim to evaluating the degree of usability and satisfaction perceived by them as a result of the experience they had doing cardiac rehabilitation at home using the vCare system. In pilot execution for heart failure use case, the following activities were performed. Daily motor activity, resistance training, vital stat control, and also e-learning materials were presented to reduce cardiovascular risk factors. Yes, and now the long-awaited part, the results. We also encountered some limitation during the development of the project. These were represented by delay in receiving the necessary equipment caused by the COVID-19 pandemic, as I said. We also encountered some technical issue. We had some problems related to the small area of the patient's houses where the system was installed and which did not allow properly camera calibration. So some patients could not use the serious games. We had a total of 30 subjects suffering from heart failure, 17 men and 30 women, with an average age of 61 years. 10 patients were smokers. From control group were 4 patients, 3 from the experimental group and 3 from the ambulatory group. We also had 1 dropout patient for the experimental group. For each of the 3 groups, the same paraclinical investigation were performed, represented by echocardiography, ECG stress test, and lipid profile, and the same questionnaire was applied at the time of enrollment in the cardiac rehabilitation program and the end of the rehabilitation program. Each patient performed an ECG stress test before starting the cardiac rehabilitation program to determine the patient's exercise capacity and for cardiovascular risk stratification of the patient and adaptation of the rehabilitation program. Statistically significant difference were found between the pre and post intervention groups, showing a significant improvement of the capacity of the exercise capacity measuring VO2 max in heart failure vCare and in ambulatory groups, while decreasing VO2 max was identified in the control group. A decrease in LDL cholesterol was found from time 0 to time 1 in both the experimental and ambulatory group, the largest decrease being observed in the vCare group with more than 30%. No statistically significant difference were observed in the control group. We found an improvement in quality of life between pre and post-intervention in the vCare and ambulatory groups measured using the Minnesota questionnaire, and here are the results. Also, we noticed a decrease of anxiety and depression between pre and post-intervention in the vCare ambulatory groups, while no difference were found in the control group in terms of anxiety, but an increase in the level of depression was observed in this group. At the beginning of the cardiac rehabilitation program, all patients who are smokers answered to the Fagerstrom questionnaire, which assists nicotine dependence. In this figure, we can see the status of smoking patients for each group from the moment of inclusion in the project until the completion of cardiac rehabilitation program. In the experimental group were 3 smoking patients and only 1 continued to smoke, but in whom 50% decrease in the level of addiction was observed. In the ambulatory group, the situation was similar, while in the control group were 4 smoking patients who continued to smoke, but in whom a tendency to decrease nicotine dependence was observed. Blood pressure values should be under 140 millimeters of mercury for systolic blood pressure and 90 millimeters of mercury for diastolic blood pressure to express medication adherence and dietary risk factors control. In our case, all patients had the blood pressure values under 140 with 90 millimeters of mercury, with an average values of 124 for systolic blood pressure and 78 millimeters of mercury for diastolic blood pressure, excepting one patient who did not measure his blood pressure as recommended. This table shows the average blood pressure values of each patient and the standard deviation. And we can see that the patient were compliant with the treatment, and the measures to reduction of cardiovascular risk factors. We noticed a tendency to improve the quality of life at the end of rehabilitation program in patients from the experimental and ambulatory group, especially in terms of anxiety, depression, and pain. While the control group, the quality of life tends to be stable and even worse on the component related to anxiety and depression. The STEPS parameters was analyzed throughout three main metrics: the number of days in which the wristband recorded the minimal amount of data, the average steps taken by subject during the monitoring period, and the adherence measure in wearing the wristband. It should be mentioned that there was time when also the patient wore the bracelet, it did not synchronize with the application and did not transmit the recorded data. Also, we missed data from patient 10 who was dropped out, and from patient 3 who had some technical issue and did not use properly the wristband. We calculate the patient's adherence by referring to the actual duration in which they were included in the project. So the lowest adherence was 2% and the highest was 38%. On average, patients performed around 2,400 steps per day, with a minimum value of 211 and a maximum value of 8,631. In this table is shown the amount of weeks in which each patient accessed at least once the vCare avatar app, the number of accesses, and the base of these parameters and the number of interaction with the system. The patient's adherence to the vCare system was calculated. All patients accessed to the vCare avatar app and interacted with the vCare system at least twice in a week. The lowest value of adherence was 31% and the highest was 93%. Through the vCare system, our patients from the experimental group were able to replace classical physical activity session with serious games from vCare Games app. Analyzing the number of sessions in which the patient accessed to vCare Motor Games app, the number of completed sessions, and the time spent in the rehabilitation training mediated by vCare solution, allow us to measure the adherence of patients in following the rehabilitation plan. Out of 10 patients, 1 patient was dropped out and 3 patients did not use the serious gains at all due to environmental condition at home. On average, subjects perform 6 motor games session, had an average playing time of 8 minutes per session. The lowest adherence in using the vCare Motor Games app was 13%, and the highest was 85%, with an average adherence more than 14.3%. Each patient in the vCare group completed the usability and satisfaction questionnaire at the end of the cardiac rehabilitation program. Even the patient who was declared dropout, were asked to complete the questionnaire at the time of withdrawal from the project in order to try to understand the reason why didn't want anymore to participate in this program. and how him appreciated the interaction with the system. Most of the patients rated the system as an element of novelty, attractiveness, and perspicuity, while the score for efficiency and stimulation was neutral. The system usability scales results obtained by a patient enrolled in the experimental group after the end of the rehabilitation period was 71. Above the limit of acceptability, and 3 patients rated the system with a score under 68. Others 3 patients rated the system with a score above 80. The highest score was attributed by patient 9 that rated the system by 88. The overall score obtained suggests that patients appreciate the system easy to use. The technology acceptance model questionnaire results showed a mean score of 30 for perceived usefulness, a mean score of 28 for perceived easy of use, and a mean total score of 59. The heart failure vCare pilot achieved almost all of the proposed KPI. Regarding the primary outcome, there was an improvement in the quality of life of heart failure patients. The greatest improvement was observed in terms of pain and discomfort and in anxiety and depression. There also was one improvement in the secondary outcomes in terms of reduction of risk factors. Only for the weekly number of corrective e-learning lessons and for weight loss changes, the results did not reach to propose the objective. As some brief conclusion and maybe take-home messages, the using of vCare system has associated with improvement of the clinical condition, increasing the quality of life, and it can be considered a safe and effective solution for ensuring the continuity of medical care and access to personalized cardiac rehabilitation for patients with heart disease. Thank you very much for your attention.
Bună ziua! O să vă rog să-mi spuneți câteva lucruri despre dumneavoastră.
Bună ziua! Numele meu este Adelina Anastase, am 55 de ani și am fost diagnosticată în urma unui infarct miocardic cu insuficiență cardiacă acum 5 luni. Am acceptat includerea în acest program deoarece am încredere în echipa de medici cardiologi și pentru faptul că acum este această problemă a pandemiei, majoritatea pacienților sunt atrași spre ideea de a sta mai mult departe de cabinetul medicului, unde deja e supraaglomerat.
Ați folosit toate dispozitivele pe care le-am instalat acasă la dumneavoastră?
Da, am folosit toate dispozitivele și mi s-au părut foarte utile, chiar m-au ajutat.
Ați întâmpinat probleme tehnice sau defecțiuni la unele dintre ele?
Am avut și probleme tehnice. Spre exemplu, la tensiometru nu mi-a transmis numai decât valorile măsurate și tableta nu le-a preluat valorile. De asemenea, și brățara nu a transmis numărul de pași efectuați în fiecare zi și nici ritmul cardiac.
Sunt suficient de clare și simple jocurile pe care le-ați jucat prin intermediul sistemului vCare?
Jocurile, da, mi s-au părut clare și simple, numai că la început mi s-au părut puțin greoaie și solicitante, probabil din cauza faptului că am avut aceste probleme tehnice, aveam impresia că mă obosesc puțin pentru că se întrerupea jocul și trebuia să reiau de la capăt de fiecare dată.
Cât de des ați folosit sistemul?
Aș fi vrut să-l folosesc chiar în fiecare zi, de 2 ori pe zi, numai că nu îmi dădea voie să-l folosesc decât o singură dată.
Ați vizionat niște videoclipuri demonstrative sau informative în secțiunea de e-learning a aplicației vCare instalată pe tabletă?
Da, am vizionat clipurile demonstrative și informative și mi-au plăcut foarte mult. Chiar am fost încântată pentru că la finalul clipului interacționam și mai bine cu antrenorul virtual.
Pe o scală de la 0 la 10, cum evaluați sistemul de recuperare cardiacă?
Sistemul de recuperare cardiacă l-aș evalua undeva la nota 7, spun asta din cauza problemelor tehnice apărute.
Pe o scală de la 0 la 10, cum evaluați conexiunea dintre tabletă și brățară?
Nu a fost una foarte bună, deoarece nu s-au transmis datele numai decât.
Cum vi se pare ideea de a interacționa cu un astfel de sistem?
Mi se pare foarte bună. Pentru mine cel puțin a fost minunată. M-a făcut să-mi schimb pur și simplu starea pe care am avut-o la un moment dat. Aveam sentiment de teamă, de îngrijorare, de depresie, iar sistemul m-a făcut să ies din toate aceste stări urâte și să mă readucă cumva la normalitate. Interacțiunea cu antrenorul virtual mi-a dat încredere, m-a făcut să-mi dispară acel sentiment de teamă. Acest sistem mi se pare foarte bun.
V-au fost îndeplinite așteptările prin participarea la acest proiect?
Pentru mine personal, acest sistem a fost benefic. Chiar sunt încântată că am făcut parte din acest proiect. Prin intermediul antrenorului virtual mi-a dat încredere și să-mi dispară acel sentiment de teamă și de singurătate.
Vă mulțumim frumos!
Mulțumesc și eu!